In this video we will talk about ventricular pre-excitation and atrioventricular reentrant tachycardia. Ventricular pre-excitation refers to the presence of an accessory pathway which takes part in the premature depolarization of the part of ventricles. There are three types of conduction pathways: a bundle of Kent, between atria and ventricles, James bundle, between atria and a bundle of his, and Mahaim fibers, between atria or atrioventricular node and right bundle branch. Any of these accessory pathways can be involved in the reentry circuit and cause reentrant tachycardia. WPW syndrome refers to the presence of the bundle of Kent in paroxysmal tachycardia. ECG features include short PR interval, delta wave, and wide QRS complex. Discordant changes of the ST segment and T wave are often seen. A pseudo-infarction pattern is often observed. The delta wave results from the activation of a certain portion of the ventricles by an impulse conduct via the accessory pathway. Another part of the ventricle is activated by the impulse conducted via the atrioventricular node. The degree of pre-excitation depends on the ventricular mass activated through the accessory pathway participation. There are three possible ways of conduction via the accessory pathway. In both directions, which is the most common. Retrograde only, thus, from the ventricles to the atria. Anterograde only, thus, from the atria to the ventricle, it's extremely rare. Generally, the accessory pathway conducts an impulse faster than the atrioventricular node. This results in a shortening of the PR interval. If conduction via the bundle of Kent is slower than one via the atrioventricular node, the WPW pattern isn't seen on a surface ECG. Three types of WPW syndrome are distinguished. Type A is characterized by taller wave in lead V1 and left axis deviation. Type B means that there is deep S wave in lead V1. Pay attention to short PR interval, obvious positive delta wave in leads 1, 2, 3, AVF, from V3 to V6 and -1 in lead V1. This ECG shows positive delta wave in leads I, AVL, from V2 to V6 and -1 in leads 2, 3, AVF, and V1. Pay attention to pseudo-infarction pattern in leads 2, 3, AVF. Type C is characterized by taller wave in lead V1 and inferior axis, that is close to 90 degrees. Pay attention to right axis deviation and positive delta wave in leads 2, 3, AVF, from V1 to V6 and negative delta wave in leads I and AVL. This ECG is recorded in the same patients as the previous one. Discordant ST segment and T wave changes are more obvious at higher heart rates. Patients with WPW patterns on the ECG and paroxysmal tachycardia should be referred for electrophysiological study with concomitant radiofrequency catheter ablation of the accessory pathway. This ECG is recorded after successful catheter ablation of accessory pathway. There are three main types of WPW syndrome: manifest, intermittent, and concealed. These traces shows intermittent WPW pattern. LGL syndrome, also called Langdon-Levin syndrome, Clerc-Levi-Cristesco, or CLC syndrome, refers to the presence of the James bundle and paroxysmal tachycardia. The ECG pattern is characterized by the short PR interval, which is less than 120 milliseconds, and normal QRS complexes. Also, an accelerated atrioventricular conduction may produce the short PR interval producing the LGL pattern. Atrioventricular reentrant tachycardia, atrioventricular reentry tachycardia, is a paroxysmal supraventricular tachycardia in patients with accessory pathways. The atrioventricular node and the accessory pathway are involved in a reentry circuit. There are two types of atrioventricular reentrant tachycardia. Orthodromic, where anterograde conduction is via the atrioventricular node and retrograde conduction via the accessory pathway, producing narrow QRS complexes. And antidromic, anterograde conduction is via the accessory pathway and retrograde conduction via the atrioventricular node, resulting in wide QRS complexes. A patient with atrioventricular reentrant tachycardia may complain of palpitations, dizziness, breathlessness, and fainting. The heart rate is usually 160 to 280 bpm. Retrograde P waves are usually visible. Atrioventricular reentrant tachycardia produces a long RP interval that is more than 70 milliseconds, compared to typical atrioventricular nodal reentrant tachycardia, which produces a short RP interval, less than 70 milliseconds. The suggestion of myocardial ischemia should not be based on discordant ST segment and T-wave changes in orthodromic atrioventricular reentrant tachycardia and atrioventricular nodal reentrant tachycardia. This ECG shows orthodromic atrioventricular reentrant tachycardia in the patient with confirmed concealed left-sided accessory pathway. There is regular heart rhythm at a rate of 197 beats per minute and with narrow QRS complexes. And this ECG is recorded after atrioventricular reentrant tachycardia termination. Vagal maneuvers, adenosine, beta blockers, verapamil, diltiazem, ibutylide, procainamide, flecainide, and propafenone may terminate atrioventricular reentrant tachycardia. Pre-excited atrial fibrillation is one of the most life-threatening arrhythmias. It's a combination of atrial fibrillation and WPW syndrome. The ventricular rate is very fast and irregular, signs of pre-excitation are present. There is a very rapid ventricular response that may degenerate into ventricular fibrillation. Ibutylide, procainamide, flecainide, or propafenone may be used in hemodynamically stable patients. In hemodynamically unstable patients, synchronized cardioversion is performed. Catheter ablation is preferred. For atrioventricular reentrant tachycardia termination, vagal maneuvers and adenosine are preferred. If they failed, verapamil and beta blockers are used for orthodromic atrioventricular reentrant tachycardia. Ibutylide, procainamide, flecainide, or propafenone are used in antidromic atrioventricular reentrant tachycardia. Synchronized direct current cardioversion is used in hemodynamically unstable patients or drug therapy failure. Thank you for watching this video. Please like and subscribe.